Alyssa, just let me know when I'm live. It doesn't show on my end.
Are live.
Okay. Good afternoon, everybody. My name is Sonali Wilborn. I think we're going to give everyone a minute or two more just to get logged in before we get started with the presentation. I appreciate everyone joining today, and hopefully you'll walk away with some good information. So while we're waiting, I just wanted to give props to a couple of really accomplished ladies behind the scenes who've done some incredible work to bring this to all of you today. Their names are Alyssa Katz and Kimberly Workman. I know they're kind of the masterminds behind setting this all up. So thank you very much, the two of you, for making this all a reality and making it happen. So before I get started, Alyssa or Kim, can you let me know if this is a good time to start, or you want me to give it another minute for other folks to join?
Let's get started.
Okay, outstanding. Good afternoon, everybody. My name is Sonali Wilborn. I'm the Chief Medical Officer for Heart of Hospice, also now known as Care at Heart. I am talking to you today about advanced care planning and the importance of it. I'm hoping everybody gets a chance to take away some good information and really promotes the idea of advanced care planning for the patients that you are caring for. It really doesn't matter whether it's patients that are, in nursing homes, assisted livings, in the hospital setting. I think it's really important for everyone to have put together an advanced care plan, recognizing that, of course, some patients that have an advanced progressive medical illness probably are more urgently in need of putting that together. Just a little bit about myself. So as I mentioned, I'm the Chief Medical Officer at Care at Heart. I have a background in hospital medicine, followed by palliative medicine and hospice. I've now been doing hospice and palliative medicine for about 14 years. And over the course of the past 14 years have had an incredible opportunity to work with tremendously wonderful organizations. And I will say that my experience with our team at Care at Heart has been just absolutely outstanding. So with that, I will also share with you that as a provider, I have certainly learned over the years the importance of advanced care planning, especially for our patients and our families. And I have also recognized, I think, that for us as healthcare providers, oftentimes this is not a skill that's taught very well. In fact, I will say that when I did med school, which I know for some of you looking at me would probably think that it was back while the dinosaurs roamed the earth, right? Because that's what my kids would say. Basically, we had no classes on advanced care planning. We certainly didn't have classes on the importance of hospice and palliative medicine. So as I've spent a lot of time practicing palliative medicine and talking to patients and families, I've done a lot of reading, learned a lot of techniques, which I think are useful, and I'm going to share some of those techniques with you, and hopefully with some of the rationale for why advanced care planning, what it is, and why it is so important. So without much ado, let's go ahead and jump right in. So here's a brief overview of today's conversation. So our goal for today is really to talk through what advanced care planning truly is, identify and give you a brief understanding of what an advanced directive is. Also, hopefully we'll walk you through some ways to have a good advanced care discussion, recognizing that these are not easy conversations to have. In addition to that, I'll talk us through physician billing, because certainly there is a recognition that advanced care planning is an important part of patient care. And a few years ago, we recognized that and have now billing codes that have been assigned to advanced care planning discussions, certainly encouraging physicians, other providers to utilize those billing codes when you are doing the work of advanced care planning with your patients and families, and then hopefully leave you with resources on advanced care planning. At the end of the presentation, I know Kimberly and Alyssa will make sure that we get a PDF version out to everybody, so you should have that as a reference. So, you know, one of the things that has struck me in my career as a hospice and palliative care physician is that the number of times that families and even patients have actually spoken to me about they wish they had actually availed of hospice sooner. So this is a statement that I hear over and over again when there is such a fear that exists in our communities about what hospice represents. And unfortunately, a lot of patients and families avail of hospice really in the last few days. If you look at the National Data Bank, what you'll see is that there are at least, almost, if you will, the majority of the patients that got hospice really were on hospice for less than 30 days. And then if you look at the number of patients that actually had hospice for less than 7 days, that percentage is almost as high as 30 to 40% of the patients who really got hospice and were only able to get the benefit of hospice for about 7 days or so. So again, part of the reason why these transitions to hospice get delayed is because it is very difficult to talk to patients and families about advanced care planning. It's extremely difficult to sit down with a patient and family that you have taken care of for several years to speak to them about their chronic medical illnesses and how we are at a point where we need to start making some decisions and recognizing that the disease is advanced and almost terminal. So what we certainly see consistently is that many of our patients who get referred to us late, their families and the patients themselves, will often send us letters and cards and sometimes phone calls or have conversations with members of the care team communicating that they really truly wish they had had the benefit of hospice sooner. So prior to jumping a little bit more into detail, I wanted to present a few facts about advanced care planning. Hopefully getting this information will help you recognize as to how we as healthcare providers really need to support our patients and families about having these discussions. So with studies that have been done over the past several years, over the last decade or so, what we have identified is that multiple studies have indicated that 90% of all of the patients and families who were polled really felt it was important to talk about their loved ones' wishes for end-of-life care, right? So there's 90% of the people felt that it was an important discussion to have. However, only 30% of them have actually done the advanced care planning with their loved ones and with their providers. Now, in addition to that, the data suggests that African Americans are much less likely to complete an advanced directive than their Caucasian counterparts. This is certainly something that I have experienced as a healthcare provider. And in fact, because of the disparity with how African American patients tend to far less avail of hospice than their Caucasian counterparts, we have actually, in many instances in my prior organizations, we've actually done a focused effort and pulled together projects on really helping the African American community and identifying support systems that will truly help them get to the understanding that advanced care planning is important. So the other interesting thing that I wanted to share with you is that most most of us here in the US today learn about advanced care planning or have an understanding of CPR or resuscitation. We get that information not from our healthcare providers, but we really get that information from the media, which I'm sure should have every one of us that's on this call today scratching our heads going, I mean, it is such an important healthcare decision. And instead of getting the information from healthcare providers, the majority of perception and reality for many Americans today is really what they hear from the media. So let me share with you just an interesting study that had been done. This was actually done several years ago, was published in the New England Journal of Medicine in the late 1990s. So here's what they conducted a study looking at how cardiopulmonary resuscitation gets portrayed in the media. So they looked at the television series, right? Because a lot of patients get their information from watching television, watching the news. So when they looked at 97 television episodes, what they identified was that there were 60 occurrences of cardiopulmonary resuscitation, and 75% of the patients that underwent resuscitation on television survived the arrest. Now, what the reality is, however, is that in the elderly patient population, certainly the ones that many of us are caring for, the elderly or the patients with multiple chronic comorbid conditions, the actual survival rate is less than 5%. Huge disparity in what is being portrayed. Now, if you add in patients who have advanced stage 4 cancers, that survival rate is less than 1%. So again, if we pay close attention to where our patients and our families are getting information about cardiopulmonary resuscitation, recognize that we've got a little bit of an uphill task as healthcare providers, and certainly a huge opportunity to take on the responsibility of doing appropriate advanced care planning discussions. So without much ado, I know we've talked quite a bit about advanced care planning. Hopefully, I've presented a case for why I think it's important for us to take this on. Let's talk about what advanced care planning is. What is the definition of advanced care planning? So advanced care planning is really an opportunity where individuals make decisions about their care preferences, and they do this in advance in the event they are unable to speak for themselves when they get truly ill. So that's what an advanced care plan is in general. And remember, much as we talk about this all being sort of one entity, there are really three components to an advanced care plan. And the three components are one, which is an advanced medical directive, and we'll talk about that further in the discussion. The second component is designation of a healthcare power of attorney, which is also something that we'll address down the road. And then the third component is really identifying what the patient's wishes for care are at the end of life. So this is an opportunity for a patient and the family to express what they want to do with things like nutrition, how do they want things handled when it comes to being treated for infections, etc. So important to recognize that there are three components really to advanced care planning. And remember, all patients, right, all individuals, every single one of us, it is our right to be able to make our own healthcare decision. And it is also our right to establish the goals of care for what we want and how we want our care delivered in the future. So again, just giving you a little bit more, what we can do as healthcare providers. It's really important, again, as healthcare professionals, for us to educate people about why it's important, right? Why is it important for them to put together a plan for how they want their care delivered? I will tell you, there is nothing that is more distressing, and I'm speaking from personal experience. I was born and raised in India, and I have my maternal grandmother, unfortunately, who passed away about 4 years ago. We come from an educated family where all my grandmother's children are all extremely educated, and unfortunately, as we got towards the end of her life in the last 3 months or so, despite everyone in the family, all of her children being educated, there was such significant discord in how they wanted her care delivered, because unfortunately my grandmother did not get a chance to actually put together her advanced care plan. I will tell you the impact of that has unfortunately been where my mother and her sisters unfortunately have now got to a point, because of the distress and the discord that took place during the time that was really important when caring for my grandmother, they're left with a poor relationship, and that's what's resulted. I know it would cause my grandmother an extreme amount of distress to know that her care has basically left behind a situation where her children, who were otherwise extremely close, are now at loggerheads with each other. So I will tell you from my personal experience, from experiences that I've had with my family, I think it's really important for us as healthcare providers to truly educate our patients about the importance of putting together an advanced care plan, identifying what their preferences are, making sure that they understand what the benefits and burdens of the decisions that they're making, and please make sure that when you do have these discussions with the family and the patient, that we're documenting this in detail in the medical record so we can always go back and reference it. So I think, as I mentioned, there are 3 components to an advanced care plan. One of the key components is an advanced directive. Remember, an advanced directive or an advanced medical directive, depending on whichever terminology gets used, that is really a legal document that records an individual decisions. So during an advanced care planning discussion. So when we as healthcare providers sit down with the patient and family to have an advanced care planning discussion, we are basically recording what those decisions are on an advanced medical directive or an advanced directive. Recognize that once an advanced directive is put in place, it really does not expire. It stays as is unless there's a new one that gets completed, which will then invalidate the previous one. So one of the things to remember, of course, is when we're completing an advanced medical directive, to make sure that we are referencing we're clearly referencing the date and the time that the discussion did take place. The other piece of information to be aware of is, an advanced care plan, an advanced medical directive is not something that is a one and done deal. So remember, our patients, when we have the discussions with them, hopefully far upstream from when they're getting to a point of being towards the end of their life, remember the patients their medical illness is changing. They have acute events that may change the course of their overall prognosis. So an advanced medical directive is intended to be fluid in the sense that it needs to be readdressed. So again, it's not a one and done. It needs to be readdressed. Certainly when there's been an acute change in condition for the patient, certainly when there's been a hospitalization or a catastrophic event that takes place, making sure that we recognize that an advanced medical directive does need to be and can be readdressed, as can an advanced care planning discussion. Also, something to remember is that when we have what we refer to as a living will. So when patients and families have kind of put together their wishes, but it's not on an advanced medical directive, even if they've outlined their wishes and it's not on an AMD, if there's an emergency, 911 gets called to the patient's home, the emergency technicians cannot necessarily honor a living will. So we really have to have an advanced medical directive, and in many instances in states that do allow what we call the physician orders for life-sustaining treatments, that is a form that needs to be filled out, because that form will basically be respected and honored by the EMTs that come to the patient's home, or it goes with the patient as they go through their various care transitions. So some of the things that I think it's important for us to know or keep in mind in advanced care and an advanced medical directive is it's valid, it's legal, it's binding, it's valid across the US. It is not something that requires a lawyer. What it really requires is a discussion between a patient, their family, if appropriate, and a medical professional who then, after having the discussion, documents those wishes on an appropriate form, which is referred to as an advanced medical directive, and signs off on it. They do need to be signed off on. So this has to be signed off by the person that we're doing the advanced medical directive for, also with witnesses, by witnesses, making sure that there is a clear witness that attests that the patient was the person who put their wishes down with their physician. So I think it's important to recognize that witnesses are needed to be recorded on the advanced medical directive as well. The last piece that I will remind everybody, recognizing that as I am speaking to you today, I'm speaking to you from a different state that I know many of you guys are practicing in. So it's always important to make sure that we have a good understanding what our states, our state laws are surrounding advanced directives. So here's a quick slide. We basically have included on this particular slide the 5 states that we practice in, that we Care at Heart do have sites in the state of Arkansas, Louisiana, Mississippi, Oklahoma, and South Carolina. So all 5 of these states do actually recognize and have adopted the physician orders for life-sustaining treatments. Each state has its own physician or has its own form. So just do remember that each of the states, there's an advanced medical directive. They also recognize the concept of a living will. There's very clear laws that govern the importance of medical, that are healthcare power of attorneys, and then of course making sure that we filled out the physician orders for life-sustaining treatment, and they're filled out appropriately, completely, with the appropriate signature by the patient, as well as the witnesses to that discussion. So having spoken about that, let's take a quick couple of minutes just to review what a POST or a POST is. Again, what it stands for is physician orders for life-sustaining treatments, or physician orders for the scope of treatment. Depending on which state you are, they call it a little bit different. And again, sometimes, so for example, I think on the previous slide I shared that Louisiana calls it the LaPost. So recognizing that's the Louisiana, which is LA, the POST as well, which talks about the physician orders for the scope of treatment. So what this document is that it basically is a document that walks through and determines really what the patient's wishes are for end-of-life medical treatment, or their wishes for how they want their care delivered in the event of a catastrophic event. So it must be signed by a physician or a healthcare provider for it to be truly valid. It must be signed. You also, in the form that gets filled out, it clearly allows the patient and the family to express their desire for the type of treatment preferences. So to give you an example, I can tell you that most physician orders for life-sustaining treatments take a patient through what their wishes are in the event they are no longer able to eat. Would they want artificial nutrition? Would they want enteral versus parenteral nutrition? So it does go and give you an opportunity to really truly share what your wishes are. The other piece that I referenced a few slides ago is that once this form is filled out, it really travels with the patient across healthcare settings. So let me give you an example. Back in the day, before the physician orders for life-sustaining treatments was actually adopted, or in some of the states across the country that have not adopted this, what happens is that when a patient is in the hospital or in a nursing home, each individual site of care delivery really has the discussions with the patient and family and fills out their own forms. So one of my biggest challenges as a palliative care provider when I was originally practicing in the state of Michigan, my biggest challenge with this was, as a palliative care physician, I would have extensive discussions with patients and their families in the hospital setting. We would put together we would put together their code status, we would fill out the forms, and then at the time of discharge, when the patient was discharged, if they happened to go to a nursing home, or if they went to an assisted living facility, oftentimes what would happen 3 weeks later, the same patient would come back with a complete change in their decisions about end-of-life care. And the reason that was the case was because Michigan happens to be a state that had not adopted the physician orders for life-sustaining treatments. So what that meant is that any forms that were filled out in the hospital were not transferable and were not accepted by the nursing home based on the state regulations. So the nursing home really had to readdress those discussions, and oftentimes when they had the conversations, the decisions made were totally different. So the important thing is that with states that have adopted the physician orders for life-sustaining treatment form, basically it helps us transition across with the patient to allow this form to travel across healthcare settings. So recognizing if a physician or a provider has taken the time to put this together, it does not have to be readdressed or recreated at a different care setting, unless, of course, the patient or the family expresses a desire to rediscuss this or wants to make changes. So also remember, the POST or the POST form are really honored by all healthcare professionals. So whether you're a hospitalist taking care of a patient in a hospital, or you're a SNFist providing care for patients in a nursing home, or you're an emergency medical technician that gets to the patient's bedside via an ER, every single healthcare professional must honor the decisions that have been expressed on the POST or the POST form. And then, of course, as you can imagine, it's important, of course, that we share this information, and it can be shared across healthcare settings. However, the one thing that I will say to you is that it does not replace or is not the same as a living will. So just be sure not to necessarily confuse the two. So as I mentioned on the previous slide, once the POST or the POST has been addressed and completely filled out, it really should accompany the patient as they go from healthcare setting to healthcare setting. Always, it is perfectly appropriate, however, for physicians or providers in different healthcare settings to review this with the patients and make sure that there hasn't been any changes with the patient and family. It is also important for us to know that we do need to let healthcare providers in different healthcare settings caring for the patient know that there is a form that has been completed. So again, remember, this is not a one and done. So once a patient or a family together make a decision and a form gets filled out, it's not set in stone such that it can never be changed again. It is a document that can always be revisited and readdressed. And when it does, if it does get readdressed and changed, the new form that gets filled out supersedes any existing and makes the older forms null and void. So typically a POST or a POST form can actually be a nice complement to a living will. And with that, let's take a couple minutes to talk about what is a living will, right? So a living will is basically a document that individuals can really put together well ahead of time. They don't have to do this. They don't have to do it at a point in their lives when they're faced with a life-threatening illness or when they're faced with chronic progressive illnesses. Oftentimes, living wills can be done way ahead of time. So I have a living will, and I put this together several years ago, as did my husband. And I think what's important about the living will that we had done with our lawyer was that it very clearly expresses to other members of our family as to how we want our care delivered, right? So this really talks more about, in general, what we want, what our wishes are. So for example, in the event that something catastrophic happens, the living will can give some guidance to healthcare providers and to patients and families on how best to provide care for that patient. So just also remember that, typically what we need to do with a living will is, you have to sort of invoke it. So if the living will that has been completed by a patient states that in the event of a terminal illness or a persistent vegetative state, for example, they would not want to continue with life-prolonging measures. They would not want to be continued on ventilator support or other mechanical supports. Then before we can follow those wishes, what we do need to do is to really make sure that we qualify the patient to be at a point where they do have a terminal illness that is incurable or irreversible before we invoke those. So a living will, again, is a little bit different from an advanced medical directive, because the advanced medical directive is, again, a discussion that's had with a physician that gets signed off. In this instance, a living will is more an expression of a person's wishes well ahead of ever getting to a point where it can be done, well ahead of them getting to a terminal illness, and certainly is put together and is a legal document. So as I mentioned, with regards physician certification, when you're referencing a living will and you've got a patient, unfortunately has a living will fortunately, but may not have completed an advanced medical directive, in those instances, remember, you have to have what's called physician certification, right? So before the living will can guide decision making, we have to have physician certification that says that the patient is no longer able to make medical decisions themselves, and also the physician has to certify that the patient does have a terminal illness or an irreversible permanent unconscious state, or a vegetative state, if you will, for us then to allow the living will to guide decision making for the patient. So there might be some other requirements as well, which of course will depend on different state laws. So let's turn quickly to the third component of an advanced care planning discussion, which I think is an extremely important component, which is designating a medical power of attorney. So what is a medical power of attorney? A medical power of attorney is basically somebody who gets designated by the patient to be the one who makes medical decisions on their behalf. A medical power of attorney should be somebody that's very carefully identified by the patient, because they want somebody who's going to be firm in making sure that they truly follow the patient's wishes. So the medical power of attorney concept allows, the concept is where we as patients, or your patients, get an opportunity to appoint an agent who will act on their behalf if for whatever reason they are no longer capable of making their own decisions. You can always designate a medical power of attorney at any point in your life. You don't have to be at a point where you're terminally ill. You can always have that designated, and then of course you can always change it should circumstances change it. Also remember, you may have a medical power of attorney, but that medical power of attorney paperwork does not get invoked unless and until the patient themselves is unable to make further decisions. So it only becomes activated if the patient is no longer able to speak for themselves. And again, I cannot emphasize, when you are talking to your patients and families about designating healthcare power of attorneys or medical power of attorneys, do encourage them to pick individuals that they know will truly represent what they wanted for their care. So I'm going to share another quick story with you, and I know I have several stories, but I think that's what you get for having had the distinct honor and the opportunity to take care of so many patients really in my career as a hospice and palliative care provider. So I had actually cared for a young woman who unfortunately had been injured in a freak horse riding accident, which really put her in, because of the way the accident occurred, she had a massive intracranial bleed, which then led to her being in a persistent vegetative state, and there was no chance for recovery of this young lady. It was extremely unfortunate and a difficult patient for me, particularly at the time that I cared for this patient. And the reason it was difficult was because, again, she was somebody who was actually my age when I was caring for her, and her children were very close in ages to my children as well. So again, it hit very close to home. The unfortunate thing was this particular patient had actually had a living will in place. She also had designated her husband to be the medical power of attorney, and her wishes were extremely clear that if she was in a persistent vegetative state or had an incurable illness, she did not want to be on prolonged life support. And unfortunately, her husband, who was her medical power of attorney, really needed a lot of support in fulfilling the wishes of his wife. Again, as you can imagine, when you are trying to make decisions or to honor the decisions of your loved one who's laying ill in the bed, it can sometimes be extremely difficult to follow through, because of course you want your loved ones around and you never want to be able to give up on your loved ones. So again, remember, it is extremely important to advise your patients about the importance of picking a healthcare power of attorney who will stay strong and really honor the wishes as were discussed. Again, I think these are things that I've already referenced on the previous slide. Remember, a medical power of attorney, even if I designate somebody to be my medical power of attorney, which I have, it does not, they cannot make medical decisions for me as it stands, because I still am fully capable of making my own decisions. The only time it goes into effect is when physicians, and in many instances it takes more than just one physician. It may take two physicians that must conclude that the patient is unable to make their decisions, and that's when the medical power of attorney does get activated. So, and then of course, remember, each state has different nuances into the extent of which the medical power of attorney can make decisions. I'll give you an example again. So in one of the states that I had practiced, the medical power of attorney could make all of the medical decisions on behalf of the patient, except for decisions surrounding resuscitation and CPR. So again, be familiar with your state legislations on what medical power of attorneys can and cannot do. Now, also remember, this is not a once it's activated, it doesn't stay active. If it is activated at a point where a patient is unable to make decisions and then the patient improves, gets better, then that gets the medical power of attorney's ability to make decisions for that patient gets revoked until such time they get incapacitated again. So it's again not something that is, you know, once it's invoked, it's not permanent. It's only valid during the time that the patient themselves is incapable of making their own decisions. Again, another instance where I cared for a young gentleman who had a severe case of encephalitis, who landed up needing prolonged care in the hospital, followed by being placed in an assisted living by members of his family. So his medical power of attorney was making all of his healthcare decisions until a point where I was caring for the patient and he had recovered pretty significantly. So I worked with a psychiatrist who was also seeing him to basically state that in our medical judgment, the patient had regained his capacity to make his own decisions. So at which point it rendered the medical power of attorney was again placed on hold and the patient was responsible for his own decisions. So remember, in the absence of a medical power of attorney, because there are many instances where sometimes patients do not get a chance to actually put this in place, there's a certain hierarchy, and different states may approach this a little bit differently. But really, in the absence of a medical power of attorney, the state, the legal guardian that gets appointed by the state, is the person that takes first precedence as far as who making healthcare decisions. If there is no legal guardian, then the patient's spouse, followed by the adult children. And typically when it's the children, there's not really, some states do recognize sort of a hierarchy of children, so the oldest gets a chance. But most states, however, really look at the majority of the children together that should make a decision. So same thing, following the children, it then goes to the parents, then to the siblings, and then after that, the nearest living relative. If, however, there is a court-appointed guardian, then that court-appointed guardian supersedes all other relatives and is the one that makes decisions. So let's turn quickly to now, hopefully that I've given you enough information about advanced medical directives, advanced care planning, hopefully told you the 3 components of it. I think what I want to do is turn the conversation to giving you some tips and tricks, if you will, on how to have a conversation. It is a very difficult conversation to have. We recognize that as healthcare providers. I think it takes a lot of practice and oftentimes a lot of preparation on our part as healthcare providers before we walk into a patient's room to have a difficult discussion with them. So just know there have been multiple books written. One of the most talented physicians and authors is Dr. Atul Gawande. He's a surgeon. He's written multiple books that have been, have been lauded extensively. I think if I would encourage everybody to read the book called Being Mortal, if you haven't had a chance to read it. His other books are fantastic as well, but certainly Being Mortal is a book that I would encourage every single healthcare provider to read, especially as we care for patients that are getting, that may be getting older, frailer, dealing with multiple chronic medical illnesses. So here's how I approach having a difficult discussion. There's multiple approaches to it. The one that I kind of work with is what we refer to as the SPIKES protocol. It's one that I've become familiar with. I find that it is a very systematic approach to having the conversation. And if you follow this process when you're having the conversation with patients and families, then it's very likely that soon it becomes sort of second nature to you and you're able to have these conversations without necessarily giving it too much thought. So what SPIKE stands for is that each one of those alphabets stands for a component of how to have the most effective conversation, right? So it's important to set up the conversation. It's important to perceive what the understanding is of the patient and understand and to get a good understanding of preferences. The third component is invitation, is I, which stands for invitation. It's important for us to sit down and make sure that our patients and families sort of invite us to share the diagnosis. So it's always good to inquire how much information that they want or what details they want shared. The K stands for knowledge, making sure that we take the time to share and describe what's going on with the patient, share with them their medical illness or illnesses, walk them through treatment options. And then E stands for emotions and empathy. So again, when we have conversations that are difficult discussions with our patients and families about decision making, about advanced care planning, about being faced with a terminal illness, remember it is important for us to recognize that the patients and families will have emotions. We have to acknowledge that, and we have to do that with empathy. And the S stands for what I refer to as strategy and summary. And the strategy and summary is, once we've had the conversation, I think it's always good to take the time to summarize what the discussion was for the patient. So I'm going to take just a quick couple of minutes to walk through the next slides that talk through each one of these components. Remember, when setting up a conversation, what I have always advised my residents or physicians that I have spoken to about the importance and how best to have these difficult discussions, I've always said to them that it's very important the first step is extremely key, which is setting up the conversation. And when I say setting up the conversation, it not only means, walking into the patient's room and telling them that you'd like to speak to them about an important healthcare decision. I think it's also setting up the conversation means making sure that we have the appropriate environment. So, for example, if you're having this conversation in a nursing home or in a hospital and the patient is in a semi-private room, making sure that we're not having the conversation when the patient's roommate happens to be in the room as well, and there's noisy family around, or there's other family members that are not this particular patient's family members around. So always making sure that you've got a private setting to have a good conversation. Also, setting up the conversation means where you get a chance to establish that connection with the patient and the family. It's never good for us as healthcare providers to walk into a patient's room, stand at the edge of the patient's bed to have an important, difficult discussion. It's always good to sit down, take your time, make sure you don't have interruptions, make sure your pager's turned off when you have these discussions, because you want to be able to give the patient and the family your undivided attention when you're sharing any difficult decision or any difficult discussion with them. So setting up the conversation is extremely important. Once you've done that, I think it's always good to get an understanding of where the patient and the family is at. So what I mean by that is, when we walk into the patient's rooms as healthcare providers, we have the benefit of an extensive chart that we've looked at. We have the benefit of talking to our healthcare colleagues that might be taking care of the patient as well. Oftentimes, it may not be that the patient and family are very clearly understanding of what's going on with them. So the best place to start is by understanding what the patient and the family knows about the illness that they're being faced with. So always ask them to share their perception of their illness. Also, it's important to kind of ask them what their preferences are, how much information do they want from us, how detailed do we need to be. So really getting a chance to sit down and understand their perception and preferences, I think, is key. And then, as I said, I think it's important to get that invitation from the patient and the family by really clearly stating, right, for them, I want to make sure that I share with you what my understanding of your illness is. And that is, that clearly states that you as the healthcare provider are wanting to give them advice on what the illness that they're being faced with, rather than presenting a more uncertain picture for them. Remember, every one of you who is a healthcare professional that may be on this call, I'm sure every one of you has had extensive years where you have studied to be a healthcare provider. So remember, our patients and families are looking to us to share our experience as healthcare providers and to give them guidance. So do be, take the time to be confident and to give your patients and your families guidance about how you think is the best approach based on your extensive, healthcare knowledge and your experience. Again, once you've shared the information, make sure that you clearly take the time to acknowledge the emotions with empathy, explore key components, which is once you've taken the time to share with them where they are with their illness, what the prognosis potentially could be. Also take the time to identify with the patient and the family what's really most important to them. What are their fears about the illness the discussion that we've just had? What is it that they find is most important for their life, right? So, for example, your loved one may say to you, if I get to a point, your patient may say to you, if I get to a point in my life where it is impossible for me to go out and play a round of golf, or I'm no longer able to pick up a book and read for myself, that they would identify those as being poor quality of life, then I think it's important for us to have a good understanding of what's really important and how they define, quality of life. Also, have a good understanding of, explore with them how much information they want shared with the family, how much the family is aware of, and how they would want us to communicate with their loved ones. And then, as I mentioned, the last thing was the Spikes protocol is really the summary and the strategy. No conversation is effective, especially when you're having a discussion about advanced care planning and being faced with a terminal illness or being faced with a chronic progressive illness. It isn't complete unless you develop a plan with the patients. So a strategy is really important. So as a healthcare provider, even when you're delivering some of the worst news, even when you're delivering to a patient that you don't have any further treatment options to offer to them, always leave them with a plan and a strategy for what happens next. There's nothing worse than to be left behind, wondering after you walk out the room and you've shared prognosis and information about their illness if you haven't provided a summary and a strategy for them. So always make sure that you have a plan that you put together and ask them what their impression of the plan is. Does it make sense that this is a plan that they want to follow? And then very quickly after that, summarize, what was said. Summarize by saying, here's when I walked into the room, here's my understanding of what you were aware of your medical conditions. I know we talked through these 5 different things. Here's where we landed, and here's the plan that we have put together, and make sure that the patient and the family kind of understand and have agreed to that plan. And then, of course, the most important part of it afterwards, when you walk out of the room, is to document and to communicate that plan. It's always important to make sure that you're communicating that plan with key clinicians that are involved in the patient's care as well. With that, I'm going to turn very quickly to physician billing. I'm not going to spend a lot of time on this. I'm going to take us through components of physician billing, recognizing again, or provider billing, if you will, recognizing I'm sure that many of you are healthcare professionals on this call who are providers probably are very familiar with this. Just remember, when it comes to advanced care planning discussions, physicians, physician assistants, nurse practitioners, clinical nurse specialists are all people who can bill for an advanced care planning discussion. And really, any patient who has a chronic progressive illness, if they're facing is qualified for an advanced care planning discussion. If you happen to be a resident in a nursing home or an assisted living facility, I think that in itself qualifies you to have advanced care planning discussions. Any patients that have early dementia, mental illnesses, when you're faced with a critical surgery, emergent or a high-risk surgery. So any patient who really has a chronic progressive medical illness or a catastrophic medical illness that they're presented with really has the right to avail of an advanced care planning discussion. Now, for us as providers, for us to bill for the advanced care planning codes, we have to make sure that we're capturing key components in the chart. So, for example, when you do bill for an advanced care planning code, your documentation must reflect, depending on the part of the country that you are and who your Medicare contractor is, there might be slight changes or nuances to it. But in general, what you need to do is have a detailed description of the discussion that you had with the patients, with the beneficiary. It's also important to make sure you've documented what the end result of that was, right? So you've had a discussion about the patient's medical illnesses, you've had the discussion about prognosis, and then making sure that you've spent the time to talk about the advance directive and really put down in your documentation what decisions were made. Also, who was present, also indicate as to whether a medical power of attorney was designated, and if so, document that as well. And it's always good to capture the amount of time that you spent in that encounter. So remember, prior to the emergency situation that we're in at the moment as a result of the pandemic, this was an advanced care planning discussion could only be billed if it was a face-to-face encounter. However, now in the face of the pandemic and because of the 1135 waiver that we have in place, that encounter can take place via telehealth as well and can still be documented and be billed for. So as far as the billing codes, remember there are two different billing codes that you can avail of. The 99497, which really is what you would bill for the first 30 minutes. And if you happen to spend more than 30 minutes and you've exceeded, 15 additional minutes, then you can bill for the additional 30 minutes with the 99498. So you can bill an additional 99498 code for every additional 30 minutes you spend with the patient in a discussion. The reason I think it's important is I will share with you, again, as a palliative care physician in a large community-based hospital here in Michigan, and when I was practicing here as a palliative care provider, I actually had an advanced care planning discussion with the patient and the family. This was a Middle Eastern patient that had 35 family members that were present. We actually had this discussion in a small conference room, and it took us about 2.5 hours to have that conversation. So in those instances, the first 30 minutes got billed for. If the codes had been in existence at that time, I would have billed the 99497 for the first 30 minutes. And then for the other sets of 30 minutes beyond that, I would have billed the 99498 4 times after that to account for the additional time that was spent. And then I will leave you with the last slide that kind of talks through, gives you some access to references. So I'd like to conclude by saying I'm hoping this has left you with a recognition of why it's important for us to have the advanced care planning discussions and to encourage all of our patients and their families to avail of this. Also, hopefully have set the stage for where our patients and our families are getting information about resuscitation. So hopefully we'll take that ownership and start educating our patients and families about advanced care planning. And then also remember the components of an advanced care planning discussion and do utilize the SPIKES protocol. If you haven't developed a technique, I do think, walking, sort of planning through the SPIKES protocol, setting up the discussion, walking through the different components of it really helps you have a good advanced care planning discussion and a difficult discussion with a patient and their family that'll leave them fully prepared for what's to come. So with that,
we just have one question if you want to address it in the last 2 minutes.
Go ahead, Kim.
It is, if the nutrition status has been addressed in the LA Post, does a living will need to be done?
If all of the components of the LA Post have been addressed, a living will does not need to be done in addition. No.
Thank you.
Dr. Wilburn, I believe you are muted.
Okay, thank you so much for joining us today. With that, we will wrap up At the end of today, you will all receive a survey link via email. You must complete the survey in order to receive your certificate. We're asking that you complete the survey no later than this Friday, and we will start sending out certificates next week.
Have a great afternoon.